Today's million-dollar question: how can we conduct secondary data analysis through an equity lens to reflect concerns around social justice? Hi, I'm Katalin, and today I'm talking to Professor Mateus and Dr. Mark Goodall to shed some light on what challenges researchers face when they are not actually the ones collecting the data, but they have to rely on data collected by others. So hi, both of you, and thank you so much for coming along today. Firstly, if you don't mind, just introducing yourselves.
My name is Mateus. I'm a professor of health economics at Lancaster University. I'm an health economist. I'm an economist by training, and then I have a master's degree in European social policy analysis and a PhD in public health. I've been working in the field of health economics for over 25 years. I think it's interesting to let you know that my master's dissertation I did in the early 90s was around equity in the use of co-payments, a comparative study about Portugal, Denmark, and the UK. So I've been interested in this field of health inequalities, health inequities, and equity at the end for many, many years.
Welcome. What about you, Mark?
Hi, I'm Mark Goodall. I'm a research fellow at the University of Liverpool in the Health Services Department. Part of my role is working within the ARC Northwest Coast. So I work within the Midas team, which is helping the teams with their methodological support. I have a mixed methods background. I've done clinical trials. I did those in Africa, and I've done clinical trials actually in the UK as well. But I've also done sort of mixed studies where I've looked at health across public health areas as well. So my background is probably a bit of everything. But mainly at the moment, it is primary care, secondary care, bit of public health, but mainly about how the health services are put together. So health inequalities has been a core part of my work, working for the ARC Northwest Coast, and prior to that, working for the Clark, which is the sort of the previous incarnation of the ARCs. So within that, equality was a key component of how we put the projects together and the lens we looked at most of the different projects. So for most of my work for the last few years has been having that focus.
So from your experiences, what have been some of the challenges that you encountered when wanting to focus on health equities, but you were dealing with someone else's data, so secondary data?
I think one of the key bits with looking at secondary data, so doing that sort of systematic reviews of other people's work, is most systematic reviews will probably have a very specific research question that they're focused on. Not always, and probably not very often. It's actually a health inequalities focused question. It's usually a question focused on other things. And from my work, that's usually been the case. So a recent one that we did was about pulse oximetry and seeing whether skin pigmentation had an impact on the actual devices and whether they were good for them or not, or had an impact. So it's not always obvious when you look at the research questions, because actually they're probably not focused on any inequalities during it. So that's probably one part that you need to sort of take into account.
How about you, Sarah?
I think that all the analysis that I've done about health inequalities, I've been using secondary data sets, data that wasn't collected by me. And one of the reasons is because if you wish to conduct an analysis that the conclusions are applicable at the national level, you need to have representative data sets, and they are very expensive. Yeah. I've used the national health surveys and also inpatient data sets and so on to address these issues of health inequalities. There are several problems, and sometimes, maybe the most frequent problem, that dimensions that might be relevant to address health inequalities, so some variables are not collected. And that is an issue because that limits the type of analysis that you can do. And I'll give you an example. In Portugal, for instance, you cannot collect data about race for historical reasons, because in the past, race was used for negative discrimination. So after some time, it was not possible to collect any information that would have the race variable in there. So you cannot conduct any studies that address health inequities related to race. At the moment, it's very, very difficult to overcome this because a lot of people that came from African countries that speak Portuguese have now been in Portugal for many, many years. So even if you ask where were your parents born, it's likely that a lot of the parents were born in Portugal. So not even now the place of birth can help to understand the changes that people from different ethnicities might be facing. And this is just an example that I know, but there are other examples. Sometimes it's also difficult to collect information about income, or people are not very reliable when they have to answer questions about income, because you have gross income, you have net income, you have income from wages, from wealth. But the worst outcome is not to do any research. So you just have to be creative in a good way, be creative and use what's available and make the most out of it. This has been my story about doing research in health inequalities in health in different settings.
So how have you dealt with these challenges then? What was your creative ways of dealing with these?
Well, sometimes you use proxy variables. So you know that, for instance, income is, either is not collected or is unreliable. This also changes from country to country. So you use a proxy variable.
Sorry, what is a proxy variable?
Yeah, that's what I was going to say. It's, it is a variable that is not in itself directly relevant, but that serves in place of an observable or unmeasurable characteristic. So for income, what we can do and what we do often, you can use level of education. We know from the social determinants of health that education usually has a quite relevant impact in your income, because it will impact the kind of job that you can get. So usually people with higher levels of education are likely to be employed in jobs that pay better. Then you have some issues around this by gender, and race and so on and so on. But still, on average, this works, okay? And then you can also add other things, but level of education is a proxy variable for income.
How about you, Mark? Are there any solutions that you found?
I think that the dilemma about the data changing over time is part of what's being described. I've looked at studies where they've described ethnicity in a particular way, and then in another way they've then decided later on that those have changed and people have either merged or separated out into different groups. So that has that sort of impact. The data sets do change over time, and I'm sure with education as well, we used to call O levels and A levels, and then A levels are still here, but GCSEs. So are they comparable? Do they work? I think, yes, using the proxy bit, trying to find something that's collected that seems the same across everybody, but that's always been the difficult part. From my view, I think the difficult bit is where the focus on the research has been. It's usually not got health inequalities in it, and therefore the challenge then is how do we put those health inequalities in? One of the ways, obviously, we can use in the UK is we can actually use data which is collected at the lower super output area, that sort of LOSA data set, which you can get from the country, which sort of puts us all into small groups. And we can broadly say, well, we know what your postcode is, we know roughly where you live, and therefore you fall into this category. Of course, there are exceptions to that, and I'm definitely one of those. I live in a very socially deprived area according to the data sets. I'm educated to a high level. So it's a proxy. It just gives us an indication. So if I know where you're from, then I can give some sort of indication as to sort of what your social background may be. That's what I tend to use.
So that was very interesting. We've heard the challenges of applying our inequity lens when conducting secondary data analysis and systematic reviews. And you have shared some of your experiences of how you have managed to overcome these challenges. But one of the questions we often get is, what if the research is not directly focused on health inequalities? Does it still need to have an equity lens applied to it?
My argument would be yes. I think you need to look at the health inequalities in it. And I think one way is obviously you can look at what area they're looking at, and you can highlight yourself what the inequalities might be. question then is, did the authors of the secondary data look at it that way? And that's where it becomes a bit of a trickier one. But I think initially it's not hard to see if you're planning to sort of look at a particular intervention, as I do with some of the reviews, like, for example, the pulse oximetry. We were able to then go, well, actually, this would lead to some inequalities in the service if the machines themselves gave inaccurate readings for different groups of people. And therefore, people would get varying different types of service, or it may then impact and produce some inequalities in how people are treated, or in fact, how it goes. And that's been the experience, is people have had poor treatment, and that was sort of in the literature. So there is sometimes in the literature some evidence of something happening that may be an inequality. So again, I think when you look at it, you can see it in the data set that something's going on. The problem is you don't necessarily know exactly how and what it may be, and that's where I think the analysis of the secondary data becomes a bit trickier. So I think you can find the inequalities, but the question is, can then you show, the next steps, and can you actually show you're having an impact on it?
Theo?
I think I don't have much to add to what Mark has said. I think that he put it very, very clearly. Sometimes it's just something that you find in the data, and it's relevant in that specific setting, but it might be difficult to draw conclusions that can be applied widely.
So, Theo, you have referred mainly to analysis using previously collected data, and Mark, you spoke more of systematic reviews. But in both cases, it sounds like the key challenge is missing variables, really, that have not been collected for different reasons. And health equities is an important part of research work, so using proxies and being creative with similar measures. So another important issue that I would like to talk about is, how do you think patient and public involvement can contribute when it comes to secondary data analysis and systematic reviews?
I don't think that the involvement of this group is relevant in the analysis, but it might be relevant in a previous step, that is in the design of the surveys and the questionnaires, the kind of questions and the issues that can be relevant. A lot of national statistical bodies have advisory committees where different stakeholders are represented. Of course, that when you're setting a survey for instance, the Office of National Statistics, you have, of course, to get ethics approval, and it's not a process that is easy. I think that the main role of patient and public involvement is in the design, not so much on the analysis itself, because the analysis, of course, is conditional of the data available. But if we can have more data available, and if we can understand the type of information that people are willing to share and to give away for research purposes, I think that is very relevant, because it can then really frame research. The availability of the data is what's more important, because we are all part of the patient and the public, even as researchers. So we also, of course, we don't have specific knowledge in many issues, but there is an experience that we have just because we are also citizens, and that can help them design in the design of the analysis.
I think there's a couple of points. I think one point is that bit about getting a sense of where the inequalities might lie. So let's say we picked a topic, like I was saying with the pulse oximetry. By talking to a patient and public group, you can get a sense of their experiences when they've had pulse oximetry in various different settings from different backgrounds. So that then gives us a good idea of where we can see the inequalities being to start with. So there's definitely an involvement, because the review has to be relevant and useful at the other end of it. So it's got to have some meaning and some benefit. So getting their voice into it at that stage to say, actually, do you know what, this was my experience. I think that's one aspect of it. I think there's another bit, which is actually sometimes the missing data there may be a reason why some data is missing, and it's not quite obvious to us as to why that data was never collected. And in fact, when you sometimes talk to the patients or the publics, they'll actually say, well, I wouldn't have given that data. So PPI is definitely there in terms of what we're doing. So it's definitely making sure that voice is coming through in what they're doing. And in terms of the analysis, it's not so much the actual analysis of any data, I suppose, as such, but it's the interpretations then that come from it. So I think having the patient and public involvement team supporting you in that level sort of helps then frame what you find, and health inequalities highlighting where they are allows us then to go, okay, this is how we would change the system, hopefully reducing them.
Agree.
Well, it's actually really interesting and fits really well with what we've heard in one of our previous podcasts on equity within patient and public involvement and engagement. So what would you actually suggest to those who are new in this field and in health research? How can they improve practice going forward?
So I think in terms of systematic reviews, there is obviously review methodology that we put into place, how we do our reviews, how we do our screening of various different articles. I think the first bit for me would be to definitely make sure that part of the initial conversation is about what are the inequalities that we can identify from the work that we're going to look at. So that's definitely one bit. And I know I keep sort of repeating that, but I think that's definitely part of it. The next bit then is to always sort of, when you're sifting through the data as you're going through it, and when you're looking at the articles, you're looking at the abstracts, you've always got that little bit of a mindset as to what you're looking for. Usually when we screen them initially, we don't usually have too many things we screen for, because otherwise it becomes very complicated. But just having that in mindset is there. So in the first initial screen, we're probably looking at the topic, the specific research question idea. But when we come to the second one, where we're looking at the abstracts, we're then looking to see what's in the data. And that's where we probably are looking to see, did they use particular data sets? In other words, is ethnicity part of the discussion? Is education part of it? Are they including those variables? When you then go to the final stage, which is, I suppose, looking at the articles, that's when I think you definitely need to have one of the variables you look for is actually categorizing them based on the thing that, as you say, may have an impact on the inequalities. So whatever that may be. The advantage with systematic reviews is part of the methodology is sometimes contacting the author. So one of the limitations is that the literature has a publication bias. So there's an element of you can't publish everything. So an article usually has a word limitation. So therefore not everything goes into the article, but it does tell you the author, and it does tell you, it usually gives you an email nowadays. So you can contact the author and say, what was your data on this? And if it's an important piece of work, I'm sure they'll quite happily share that with you, and then you can incorporate into your data. So I think there's definitely a way of doing it, just bearing it in mind as the sort of the methodologies that you would use to do a systematic review. And again, I think with all things is having more than one person's eye on it, and that's the key bit. I think for most systematic reviews, you don't do it on your own. You do it as a group of people, and you share it, and you have those discussions as you're going through it, and that includes the public involvement as well.
And what about secondary data analysis?
Well, I think that part of the problem that we are facing at the present is related to difficulties to access the data. For good reasons, barriers due to anonymous privacy of the data set. It's more difficult to gain access to existing data sets. But at the same time, we are living a moment where anonymizing the data is much easier than it used to be in the past. So we have two contradictory forces at play here. And I think that one of the issues is really access to existing data sets. So I think that it's important for people involved in the use of secondary data analysis to also be involved in ethical discussions around data sharing agreements, privacy, anonymity, and uses of the data set. So I understand I'm not advocating, for giving the data to everyone at ease. It's not at all what I'm saying. I'm very self-conscious also about my right as a citizen, and how I would like to see my data treated. But I think it's important to also have considerations about the current barriers to access data, because if we make it more and more difficult to access existing data sets, that is going to influence the type of research that we can do in the future. Okay, because if only small parts of data set are shared, or it's always the same group of researchers that can gain access to data, that is going to certainly influence the type of research that can be done. Okay, without any prejudgments about this. Okay, but it's good to have different people coming from different places and with different backgrounds looking into the same data sets, because they are going to make different questions to the same data. And I think that that is an issue that I think that researchers are dealing with at the present, and maybe it's not being discussed enough.
So there is a question about how data is used and the sensitivities around that. So clearly in this, we can use the data for, I say, good or evil. There's an element that people could use it for a good purpose and for a bad purpose. And we see that regularly reported in the news, where as researchers, we see sometimes our research being sort of reported on, and we're thinking, well, no, you've picked on that little bit because that's sensationalizing it, but actually it's not what really we were trying to do, and that leads to sort of complications. And I think that's the key bit when we are also reviewing other people's work. We probably as researchers are conscious, and we always have an element of, we look at the biases within their work, but also we look at the strengths and limitations of the piece of work we put together. So for systematic reviews, usually there is a protocol that's published with data sets. Do people do that, or are the people quite private?
You have to be transparent about methodology. You don't set it in advance. It's not current practice, but most of the times when you now try to be given access to existing data sets, you have put forward the methodology that you are intending to use, and also your research question and what you are trying to answer. So you have to make it at least transparent for the data owner. But it's still very, very difficult to have access to individual level data. And sometimes if you are not given access to the microdata, it becomes very difficult to do your research. I'll give you another example. For instance, due to reasons of privacy and anonymity, in national health surveys, you are not given access to the microdata. And if you intend to do any research that involves obesity, you just can't do it, okay? Because if you have age in groups, if you only are given the data with some variables coded in intervals, or it helps, but you cannot be precise in the research that you are doing. It's important to weigh the pros and cons for giving data that is already grouped or giving access to microdata.
Well, sounds like there are plenty of challenges out there, but it also sounds like that there are answers to these challenges, and we can overcome these if we put the effort in. Finally, we are an ambitious podcast, so we always close by asking our speakers about their vision for the future. So feel free to dream big here. So here it goes. What's your vision for the future in terms of health equity considerations?
It's probably quite easy, is that a lot of systematic reviews are published in I think Prospero is one of those different databases that exist. So you publish your systematic review. I think it needs to be one of the questions in that systematic review protocol. So when you actually register it, it asks you a series of questions. I think one should really be asking about the health inequalities within that. So I think that then at least will raise the profile of, actually, you need to consider this. I think the other bit then is the historic bit about the data sets, is that we, moving forward, have to make sure that we are aware of it and make sure we're capturing it. So being able to look at sort of longitudinal data, which is what you're sort of trying to do with the systematic review when you look at different studies, is we need to all be collecting some similar things. So if I'm working in a particular area, we should all usually be using the same measures. If we're using different measures, then that becomes a complete nightmare. And that, I think, is my hope, is that we become a little bit more savvy. And that in some ways in the systematic reviews is quite useful, but actually in practice, people don't tend to use the same measures when they're doing their own studies, partly because I think sometimes they're not trying to answer those questions. I think also moving forward, I think people should recognize that their data they collect can be used by other people to do other things. And so being aware of that means that making it accessible, and that becomes the next challenge, is when we've collected all this data, usually from sometimes studies of thousands of people, how can we then make sure that that's accessible by somebody else who may actually have a clever way of looking at it, and therefore providing us with some other answers that we may not have considered when we first collected the data.
Well, I guess that's a whole different topic on data sharing that we could go into. How about you, Theo?
I think that something that we might sometimes not consider is the relevance of the topic itself for society at large. Actually, when we are doing research on a topic, we think that everyone shares the same interest as we do. And I think that we need to be aware that the research on health equity, or with an health equity lens, is mainly going to take place if equity and social justice are a goal for society at large and are a concern in any given society. Because if the majority of the people doesn't see inequality as an issue, there is very little space for the researchers to move forward their agenda that is a positive one. Okay, and I think this is an issue that we need to be aware. And so we need to think a bit about what are the role models for the people that are doing research at the moment. You know, do we have people that are inspiring other people to do research in health equity? And what is being taught, you know, to young researchers in order to keep them motivated, you know, to research in the field of health equity. So what are the exogenous factors that keep us interested, or, you know, that draw us to a given topic? There will be plenty of issues and topics in the future for health equity research, especially if we think about climate changes and the impact of pollution and so on. So we also need to start to think about the ways on how to address those challenges and the data that we might need, and to be a bit proactive, you know, in setting up the agenda for the next 5-10 years, because it's the people that are now more on the top or at the front of the field in terms of research that can influence, you know, the research that is going to be done in 5-10 years, because they are the ones that can help setting the data collection processes, access to data sets and so on, because they are the ones involved in the wider discussions that take place and involve many of the stakeholders in the field.
Yeah, definitely. And I think what you guys were saying before, public and patient involvement and engaging the community helps with identifying these priorities and to stay what research is really needed in order to focus on health equities. So Theo and Mark, I really appreciate you being here today and sharing your thoughts on this topic with me, and of course with our audience.
Thank you very much.
Bye, everybody.
In the next episode, Rod gets to question the expert Dr. Neith McMahon about equity language. There's still time to let us know which terms and concepts you find most challenging that we should ask her about. Just use #ImplementEquity to flag these up.